This is OUTSIDE START. It's a Cilostazol bridging study. This is our 8-year experience with outpatient bridging in high stent thrombosis risk paclitaxel-eluting stents in patients who have had or were having surgery during the proven at-risk period, which per recent study extends out to 30 months with the Taxus stent. We have no disclosures. The background: dual antiplatelet agents with P2Y2 inhibitors plus aspirin obviously decreases stent thrombosis risk. We've known that for 15 or more years. Annually, 5 or 10% of patients are advised to interrupt the DAP therapy to reduce perioperative bleeding. And this premature stopping of the DAP really, especially during the first year in early generation stents, leads to high stent thrombosis risks, 35% in the first month, and at least 10 to 20% in the first year, especially in the first 6 months from prior data. Paclitaxel was recently seen to have the highest stent thrombosis rates when people are prematurely off of DAP therapy, leading to major adverse events, recently seen to be as much as 7%, extending out to 30 months per the DAPT and Taxus Liberty follow-up studies just recently presented last fall at ACC, I believe. To date, there is no real consensus as to the best bridging for patients that need to come prematurely off DAP with urgent surgery when they are in the at-risk period of need for DAP therapy following their stent. I just added this slide. So this is a new slide that was not presented at the late-breaking trials. But when I reviewed this and added it the last couple of days, it became clear that even the risk is extensive for drug-eluting stents, but also for bare metal stents, extending even beyond the known 3 months time for bare metal stents. The interesting thing about this series, representing 500 patients or more that had surgery from the European group, is that these event rates occurred while patients were on DAP therapy. Either a single DAP was continued or a dual DAP. And the interesting thing about this MACE rate is that every one of these MACEs in this series, which I did not know when I first read this, I went back and reread it several times, and even since the study was presented a couple of weeks ago at SCAI, this is even more impressive event rates while on at least one agent. And the bleeding risks, as seen here, even on a single agent, is very minimal at 4%. But if you're on dual DAP, the bleeding risk of severe bleeding is 20% or more. So it's very important that something needs to be done with the DAP therapy to prevent bleeding. But even on a single agent of DAP, that there are significant event rates in these at-risk periods. And for drug-eluting stents, we typically talk about the first year. Some of the newer drug-eluting stents suggest that maybe we can get by with 6 months. But the first generation stents, the event rate of 7 to 9% continues even out to 30 months, especially in the Taxus series. So there's a lot of patients that have these stents, and that's true for bare metal stents as well. So finding a strategy to deal with this is going to be important. To date, people have tried continuing aspirin alone. I just mentioned what aspirin alone it looks like. Heparin, which has not necessarily been successful, GP2B3A inhibitors, again, a high bleeding risk and potentially not successful and require inpatient hospital stays for 4 to 5 days or more. Low molecular weight heparin, which produces increased bleeding risk perioperatively, and a lot of people don't want to use that agent. And the success is very variable. And IV Cangalor, which was recently considered for bridging to bypass surgery. All of these agents to date have had limited or anecdotal success, variable or high cost, and or require prolonged inpatient or outpatient IV therapy in order to facilitate the surgery. Cilostazol was thought of as a third antiplatelet agent. There's a lot of data from Asia using this, where a lot of people are resistant to Plavix and or Cilostazol, the clopidogrel therapy. Drug-eluting stent studies, mostly from Asia, have shown either similar or decreased MACE rates and or restenosis with the addition of Cilostazol as a third antiplatelet agent in high-risk patients. One of the studies was a randomized study that substituted Cilostazol after 1 month for the aspirin and clopidogrel. So what happened in the study is people with drug-eluting stents were put on triple therapy, and at the end of a month they were randomized to clopidogrel aspirin versus Cilostazol aspirin, and what it showed was a low MACE rate and a 50% decrease in restenosis versus traditional DAPT therapy by 7 months of follow-up. Cilostazol is a phosphodiesterase inhibitor approved for claudication with warnings of potential problems for worsening heart failure and effects of interaction when people have severe renal failure, use of azoles, diltiazem, even omeprazole, is that the medication effect builds up and potentially doses need to be adjusted. We weren't necessarily focusing on that at the time, but perhaps that may have impacted some of our treatment intolerances. It works as a CMP, reversible inhibitor to reduce platelet activation and aggravation, and has a relatively short half-life compared to clopidogrel in the 10 to 12 hour range. Thus, depending on the timing, the dose can be out of the system as much as 90% if it is stopped 72 hours before a procedure potentially. So we try to time things in developing the regimen based on the half-life. Prior studies have suggested that there's less effect on bleeding, it's a less aggressive antiplatelet agent, and that it may be less of a bleeding problems perioperatively. We mentioned that the data, mostly from Korea, is that 50 to 60% of the people have loss of function allele with high on-treatment platelet reactivity on clopidogrel, which leads to increased MACE risks. The idea that to use Cilostazol came out of clinical necessity, was not really intended as research. It was an idea that was put forth in 2003 at a CRT conference by Dr. Waxman and Dr. Peter Berger. They were suggesting that as a potential option. Interesting enough, we decided shortly after that to try it in 5 or 6 patients in unavoidable surgeries beginning in 2005. And those were patients 3 to 6 months post first generation stent that had urgent surgeries. Now in this setting, the goal was to try to get them through the surgery, and at that time the DAPT regimen for sirolimus was recommended to be 3 months and paclitaxel 6 months. People were having variable durations of DAPT therapy, and that's where we started. That's where our less than 6 month data came a lot of out of that series between 2005 and 2007, where the recommendations were for 6 months of therapy and eventually extended out to 1 year by 2008 and 2009. So a lot of the high-risk data became out of that high-risk period in 2005, 2007, and in our center, 90% of the stents were paclitaxel. This was not intended as research. It was a retrospective series. As we became more comfortable, we started using it more often. The patients were presented with all the other options. Surgeons were pretty much bleeding at birth, did not want to have low molecular weight heparin or GP2B3, and a lot of patients didn't want to have inpatient therapy. So in that setting, they wanted aspirin and clopidogrel to be stopped. In retrospect, this was a very high-risk population with not known at the time, very high-risk paclitaxel stents with high thrombotic risk, undergoing, as we've seen, a very, very high risk of surgery for MACE events. And I don't think that this study could be repeated in the present era with stents that are potentially less thrombotic, and that now that we know that perhaps continuing the aspirin is a better strategy. So when it comes to proceeding with this was a retrospective study. By 2008, we had 28 patients with urgent experience, and then we began to extend this to higher bleeding risks by adjusting the timing of the DAPT therapy. and also 2 patients that were more semi-urgent after 1 year. And when we saw that there were very late stem thrombosis risks, we actually decided to bridge people out to 5 years by 2008 and thereafter, and additional experience was gained in the long-term follow-up of people anywhere from 1 to 5 years post-DAPT, post-stent on DAPT therapy still. And in higher risk bleeding surgeries where we thought that we would need to adjust the period pre-op when the bridging therapy would be stopped. So our regimens eventually were tailored such that both DAPTs were stopped 8 days pre-op after that dose, and then ideally 100 milligrams of cilostazol twice daily was given starting on the 7th preoperative day. And for the low to moderate bleeding risk surgeries, cilostazol was stopped 24 to 30 hours before, which meant that maybe 30 to 50% of the medication was still on board. And then the surgery was done, and then DAP was resumed 12 to 24 hours. At least that was the advised goal. Now, surgeons sometimes didn't always comply with that if there was concerns about bleeding or they weren't 100% comfortable with their hemostasis, that they may delay that longer. For high bleeding risk surgeries, including epidurals, urologic, and back surgery, which are definitely high bleeding risk surgeries that either require a lot of attention to hemostasis and or significant risk if bleeding were to continue, the same therapy was used, but the cilostazol was stopped 54 to 60 hours before, ideally with a goal of 1,000 milligrams given preoperatively. And then the surgery was done, and then we actually delayed DAP resumption to the advised time of 24 to 36 hours. Now, some surgeons may have delayed that longer. Not every patient tolerated cilostazol. Some of those interactions may be related to those patients with poor renal function, or that may have been on diltiazem or may have been on omeprazole. So inadvertently, some patients had side effects. We reduced the dose to 50 milligrams twice daily, and we're very adamant about them calling us if they had problems at that point. Occasionally, we had to tailor the dose even further down. But in all, because of the shortened protocols for some people that had spine surgery or high-risk bleeding, we note that if patients had at least 500 milligrams, 600 or more, that these were considered adequately bridged. If you're only getting 10 doses of 50 milligrams twice daily, then ideally 500 milligrams would be the target in someone with a high bleeding risk that can't tolerate the medication. We considered adequate therapy if more than 500 milligrams of cilostazol was given preoperatively, and especially that DAPT was resumed by 48 hours post-op. So 108 patients were retrospectively reviewed with 183 consecutive surgeries in which DAP was advised to be stopped, that meaning both DAP. 9% had side effects. Typical side effects include headache, upset stomach, palpitation, dizziness. Anyone who's used cilostazol knows that not every patient can tolerate it. We led these patients to reduce their dose. Occasionally, when our investigators were away, the patient called the surgeon. They realized that they were still on some blood thinners. Occasionally, the surgeon stopped the medication without calling us. And this is how some of our under-bridged patients came about. And some patients, when they had side effects, they simply just stopped taking it after 1 or 2 doses, didn't call us, went for a week without any therapy, had their surgery, and said, well, gee, I don't need to put my DAPT back on because I've gone a week and I don't really need it anymore. Sometimes that was the surgeon's decision or they overlooked that, and sometimes that was their comfort saying, this is my opportunity to get off these blood thinners that are expensive. So in the end, almost 60% of the patients had the full 1,300 milligram pre-op protocol. Another 32% had 1,000, and another 10% due to side effects had 650 to 900 milligrams. Or if there was a really urgent surgery, sometimes the cilostazol bridge was shorter than the 7 days, that it could have been 3 or 4 days depending on the urgency of the surgery. 8 patients had inadequate therapy. 12 patients overall didn't complete the full protocol. 8 patients didn't resume DAP. Now, 8 of the patients had one or the other. 4 of the patients had both, where they didn't have adequate cilostazol and they didn't resume the DAP. So the bridging therapy, low bleeding risk, dental oral surgery, dermatologic procedures, moderate bleeding risk. The biggest portion here was GI procedures with endoscopy, orthopedics and gynecologic procedures, and occasionally bypass surgery. So we do have bridging of non-cardiac and bypass surgery. And then the highest other group was the high bleeding risk, which from 2008 was the modified protocol for higher bleeding risk surgeries, predominantly back surgeries and epidurals, some urologic and some high-risk ophthalmologic surgery. So in 183 patients, they actually had a fair bit of at-risk drug-eluting stents of 42 millimeters. That's relatively high-risk off-label therapy with an average of 1.7 stents per patient, diameters of 3.1, with some of the stents being down to 2.5. We know that the smaller the stents, the higher the risk. So overall, in our 183 patients, 171 patients were adequately bridged over the 5 years at an optimal dose of 500 milligrams or more, with DAP being resumed by 48 hours. In these 171 patients that had the ideal amount, there were no events, surprisingly 0 events. Of these, 132 surgeries were bridged in the first 30 months with paclitaxel-eluting stents, following their paclitaxel-eluting stent being placed. With the same protocol, adequate amount of DAP, more than 500, and resumed by 48 hours, those 132 surgeries were successfully bridged. What happened with the event rates? There were MACE events. In that first 1-year period, 55 patients were bridged in the highest risk set in the first 12 months post paclitaxel-eluting stent, and there was 1.8% event rates versus a historical rate of 10 to 25% as noted in our background information. This is a summary of all our bridging periods, how far after surgery, whether there was MACE or not, and you'll note that patients that had the adequate dosing, even less than 6 months, as little as 2 weeks after surgery, put stents, and 2 weeks later, if we decided it wasn't working, they needed bypass surgery, we had too many lesions. As little as 2 weeks after the placement of a drug-eluting stent, no MACE, provided they were bridged with cilostazol per our protocol, and that's out to 60 months. And the patients that were inadequately bridged with cilostazol and or did not resume DAP, 8 of them got away. 8 out of 12 got away with it, and 4 of them had events. And when were the events? One was at 7.5 months. That was in 2005 when the recommended duration was 6 months for DAP therapy. One was at 12.5 months, and another one at 28 months. And surprisingly, despite the DAP study recently showing paclitaxel stents are out to 30 months having events, there was an event at 40 months with inadequate bridging. These patients that had inadequate bridging, of the ones that had MACE, they had 100 or 200 milligrams in 2 of them of cilostazol, and the other 2 didn't take any cilostazol bridging whatsoever off of both the DAP. The ones that didn't have events, that didn't have an adequate dosing, did not resume DAP for the most part. So the majority of the 4 events were after 1 year, surprisingly, in this high-risk paclitaxel-eluting stent group. Now, we knew that there was beginning to be some very late stent thrombosis risks, but we didn't know until last fall what the exact percent was until the large series of paclitaxel-eluting stent follow-up was done in the DAP sub-study. We mentioned about the events. The events usually occurred post-operatively. 3 out of the 4 events occurred either on the 2nd or 7th day post-operatively, and one of them occurred pre-operatively on a patient that was completely refusing to have any DAP therapy and refused to stay in hospital prior to his bypass surgery. The interesting problems with this study is that most surgeries today don't stop aspirin because of what we've learned from the earlier series that I mentioned from the European series by Patrick Serres. Thus, our patients may be theoretically at higher stent thrombosis risk than any other studies to date. So we really don't know, what the true background risk is off of all antiplatelet agents when the event rates are as high as we saw in the historical European series on at least one DAPT. We know that surgery is a very difficult time. It's a retrospective study. It was not intended as research, so it's very difficult to exclude protocol violations and to control patients that weren't on therapy and that had stopped therapy due to personal preference or to surgeon preference and or to oversight. So I think this is a hypothesis-generating study and that really needs to be reassessed in current generation of drug-eluting and bare metal stents with all current antiplatelet agents currently in use and respecting current DAP duration guidelines. The important thing is that in reproducing these results, that the bridging success requires strict patient interaction. They need to call the protocol cardiologists and make sure that they're on therapy, report any side effects. We need to have interaction with the surgeons and make sure that they're on board with continuing the blood thinner, that they're comfortable with the bleeding risks, and that they are comfortable resuming DAPT in a reasonable setting. Any deviation from this is going to produce events potentially, and what to do with these: inpatient monitoring, alternative bridging, consider canceling the procedure and or insistence on resuming DAPT as soon as possible. So in this study, in summary, we've proven, at least in our patients, that we have a low bleeding risk. There was no significant problems with bleeding. Those were our event monitoring. Bleeding risk and perioperatively and event rates MACE-wise by 30 days. And that in the highest risk paclitaxel-eluting stent group, that the stent thrombosis risks are pretty much non-existent and or very minimal if the Cilostazol and DAP resumption protocols are followed. This is just our summary slide, and I want to thank you for your attention and open up to any questions that may be generated from the audience.
Thank you, Dr. Laham, for an excellent presentation. This is pretty much a very overlooked topic at times, and that's why this is a very interesting study with a long follow-up period. I'm speaking on behalf of Subhash, and he got kind of stuck between airports. That's why I'm asking on behalf of him. So I have two questions for you before everybody starts out.
Sure.
Number one is that why is Cilostazol effective in preventing peri-procedural events? Like, what is the underlying mechanism?
I think that it does. It prevents platelet activation and aggravation through the CAMP method. So it is an indirect antiplatelet agent that has similar effects perhaps to a GP2B3 inhibitor, but indirectly, and it's much a weaker effect. But in some patients that have no responses to clopidogrel and to the thienopyridines, that this actually has been shown in the Asian patients to have some antiplatelet effect. Obviously, you want to have some antiplatelet effect to prevent thrombosis, but by the same time, the surgeons want nothing to do with bleeding risk. So having an agent that's a shorter half-life, potentially timing it correctly to get it out of the system by the time the surgery occurs, and then getting DAPT back on board.
I see.
It's the best, So you want to have a bleeding. It's almost like It's almost like the analogy with Coumadin. You want to have some fresh flows in plasma, reverse the effect during surgery, but have a temporary effect such that the anticoagulation kicks in again. It's almost an analogy that I would use for how this was planned. This was really not planned, but we got an idea, and we said, well, gee, if they're using it, maybe the major centers using it. But 3 years later, when we found out, we asked these same people whether they were using it. We already had 60 patient experience by the time that we found out that they're not using it anymore.
I see. Interesting.
So it wasn't my idea. It was a clinical survival, and quite frankly, I don't think that we could duplicate this in a randomized study now without FDA approval, because I think this is a really hot topic. But frankly, I didn't realize even until last night what the thrombosis risk was, and it's much higher perioperatively, even with people on blood thinners.
True. Very true.
On a horse, and chest, prayer, namaste, we go open them up.
I see.
Palms straight up, fingertips to the wall, exhale, don't come out of your squat. And again, breathing in and exhaling out.
I can't hear the question, but
I see. So my second question is, how does intravenous cannular fit into the non-cardiac surgery bridging protocols?
To date, the majority of the cannular data is about the same size, maybe 200 patients, was done pericardiovascular surgery. Now this requires, as best as I can remember, a 72-hour infusion preoperatively, and potentially was recently approved by the FDA for this role. Now, one thing is, this is inpatient. It's not available at every hospital. It's probably only, going to become selectively available. It's not available at every pharmacy, such as Cilostazol, and it has to be done in a hospital with close monitoring. This is an interesting, study that we were able to achieve, even though it wasn't planned as a study, by having this done as predominantly as an outpatient.
I see.
Cilostazol is available at every almost corner store pharmacy, and it's not anywhere near the cost of an investigational drug that will be obviously expensive and require 3 days of insurance approval preoperatively. We see how difficult it is to get things approved for patients to come in. How are we going to justify the insurance company come in for a week of therapy? That's going to be a hard sell. By the time you get approval, the surgery probably either would have happened or you would have had to find another strategy. So I think that there's going to be a bigger role, obviously for cannular, but it's probably not going to be widely available, in the next year or more.
I see.
In this situation at every hospital. I do think that we're going to require more studies, and the possibility was raised of getting an NIH grant because this is a public health issue. Obviously, with a generic medication, people are not going to, people from the drug companies or from the clinical centers aren't going to jump into this study because there's not a lot of financial gain to run a trial. But I think that this is enough of a public health issue with 2 million stents or more placed per year and 5 or 10% of them needing surgery. And that's not surgery in the first year. That's surgery annually out to several years. We don't know. The event rate with the newer generation stents out to 6 months a year may be relatively low, but it's not zero. If you do enough surgeries, you're going to see events.
I see. Thank you so much for that answer. And please, anybody, please feel free to speak up for any questions.
Charles, this is Nick Shamas here. How you doing?
Hi, Nick.
Great talk like usual. Just a quick comment. First of all, we need to say that this is a very thought-provoking study, no question about it. It's hypothesis generating, big time. Very important problem. We've had patients every single day that we ask the question what we're going to do with their DAPT, before certain surgeries. So, just to find out that Cilostazol, can potentially be a safe bridge, to those patients is a tremendous, at least hypothesis generating finding, till that's proven, of course, by prospective, hopefully a randomized study. And I have to say the credit is all to Dr. Laham, for doing this study. I had the opportunity to join very late on this study, and I always thank him for even including me. One thing is nowadays, the issue of aspirin, and I'm just going to ask Charles about this. Nowadays I tell my patients just don't stop aspirin before surgery. The only time, I tell them to do that if it's a neurosurgery or a spinal surgery, and of course, then you end up with the question what to do with those patients. But most surgeries now, I would say 95% of the time, and I don't know what you guys experience, whoever's on the line can share that experience with us. but they go with aspirin on board, and they really do very well. And there has been some studies, that showed, that stopping aspirin actually can become a potential issue, for a very select, very high-risk patients, but the majority do really well. So here in this case, in this study, we just simply have no aspirin, no ADP receptor antagonist. Essentially we're cutting off everything. We're just staying on the Cilostazol as a bridge. How is that going to play in today's day-to-day practice with aspirin on board? Have we had any patients, Charles, where patients were kept on an aspirin along with the Cilostazol, or they were completely off the aspirin here?
In the larger series, we do have some with aspirin, not in this particular review, but we do have, and most people are recommending keeping aspirin. And short of a bleeding risk, like you mentioned, with epidurals and with neurosurgeries, or some of the prostate surgeries where there's really adverse events with bleeding, continuing aspirin ideally is going to lower some of the event rates. Now this slide, I put the slide up again. This is the European series, obviously with first-generation stents, and I imagine that there's a lot of taxes, and I'd have to go back and look at the actual study itself. But this was the slide showing event rates on single therapy and on dual therapy. So every patient in this European series that had, and on this slide had very high event rates, every one of them was on at least one agent. So 50%, 55% events in people that were on a single agent, I presume that that's aspirin. But I mean, either aspirin or Cilostazol. Clopidogrel. And then, obviously the MACE risk was still present with dual antiplatelet therapy, but look at the bleeding risk, 20% or more severe bleeding, and that's not just nuisance bleeding. So I do think that aspirin is probably the standard of care unless there's a significant bleeding risk. But to accumulate enough data without aspirin, I don't think this study could be duplicated, because the more we learn, the more it's becoming less attractive to do bridging in less than 6 months or 3 months, or unless it's urgent. So I don't think this historical data can be mimicked.
Yeah. It's just interesting you say that, because if you look at the dual antiplatelet trial, the randomized trial that was recently published, and it's amazing that in those first generation stents, particularly the packaged Accel-based stents and the sirolimus-based stents, the old stents, that we've had, the Taxus and Cypher, and you can see that at 30 months, once the dual antiplatelet therapy was stopped, and patients were kept only on an aspirin, you can see the curves start to change toward higher event rate, and that's almost 30 months, after the actual initial procedure. I really think this is going to impact the guidelines somehow, where it's going to probably allow patients to be on DAPT for a longer period of time, especially those who have received first generation stents and those who have a very high ischemic potential, and like left main stenting or trifurcating stenting and so forth, and so that still is very relevant, in today's practice, because we have a lot of those patients who have had first-generation stents, which we will see 2 and 3 and 4 years, and even though we don't use them anymore, pretty much are gone. Still, these patients we're going to be encountering in our practice, and you've had data as long as several years, post stenting. So that's pretty remarkable to see that even several years after, where the event rate is reduced, and even several years after, when patients are completely off the DAPT, there is a higher event rate, which actually matches pretty much with the DAPT randomized trial in terms of the higher event rates that we see in those patients years after their PCI. So I think in many ways, I think this is a kind of confirms that we still need to have some bridging for those patients, particularly those, with high ischemic potential, and particularly those, with, a first-generation stenting.
Well, that's an interesting thing, Nick. And I think we're going to see. I know Kirk very well. I've known Kirk Garrett for 15 years. He was one of my colleagues at at Mayo when I was there, and he presented the both the DAPT and the Taxus Liberty follow-up. These patients are going to be followed. We've seen 30 months, but I guarantee you that there's going to be 3 and 4 year follow-up, and you're going to still see events. Now the question is, do we accept a 3 or 4% event rate as seen in in these slides here from the European series, or is that acceptable enough?
Yes.
Even in these bare metal stents at 3 months, I actually personally are using the bridging in those patients. Bare metal stent at 4 months they need surgery. I use bridging if they're still on DAP. And the funny thing is that the event rates in people that have stopped their DAP, even not having surgery, are out to 90 days. They don't come right away. They come, 5, 10 days, especially the majority of them, but there's still some late events. And we don't know if some of the restenosis that occurs, gradually over the next 3 months or so isn't from being off the DAP. I don't think that anyone studied that. I don't think that, anyone's done the serial follow-up every month after off DAP compared to on DAP. Is there a difference in the restenosis? I would think that some of the late events and repeat procedures, even 5-6 months later, are from the interruption of the antiplatelet agents, but proving that's going to be very difficult. What's our comfort level? Is 4% event rate as shown here, or 6% acceptable risk, or 7%, at 30 months? I really feel that the majority of patients should be bridged if possible.
Oh, well, ideally 0 event rate, right? Like you showed.
Well, if we had a 5 or 6% event rate when stents were first put in, when we didn't have the DAP therapy figured out, we would have been very happy. But in this day and age, is 1 or 2% risk going into a surgery even legally acceptable in a very litigious society? I don't even think we know the risk of the things that we're doing. And we may get the patient through the surgery, but 3 months later you realize their EKG shows a silent MI. I don't think we even have touched how many events are actually happening.
Yeah. So do you think we have enough data to go to the NIH and do a multi-center prospective randomized trial to show that possibly we have some safety in bridging and with less potential bleeding complication with Cilostazol at this point, based on the outside start?
I think that is true. I think that we would potentially, and Roxana Miran called this a phase 2 trial, even though it wasn't a phase 2 trial. A phase 2 trial meaning 1 to 300 patients. We actually had a phase 1 trial. We were finding the dose at the beginning. Really, we didn't plan it that way, but I don't think this could be duplicated. But I do think a phase 3 trial with 1,000 patients to 1,500 patients could settle this question. One of her points was, well, I don't like the fact that there weren't any MACEs. Well, you know what? Patients take 1 or 200 doses. Is that considered a MACE? Drug companies would probably have to report it, but is it really temporally related to the medication when it has a half-life of 10 to 12 hours and is gone by 120 hours completely out of your system? So, attributing events to that is interesting, but I think that there's a basis here.
Right. I think it's a major public health issue, like you mentioned earlier, and I really believe we shouldn't be stopping at outside start at this point. Probably the next step is warranted to go up for more of a prospective evaluation, randomized evaluation to this particular question.
That sounds good.
Thank you.
Thank you very much. Thanks, Nick.
Thank you, Dr. Shamas. Thank you, Dr. Laham. Thank you. Thank you for an excellent study presentation. Indeed, this is a very, I would say, an overlooked topic and a public health issue. I agree with your comments on it. And, I think the next step is obviously to do a prospective randomized study and go forward with that. And thank you so much, everybody, for attending today's presentation. And you could continue on with your routine work. Thank you. Thank you all.
You mentioned there were some CMEs, is that right?
Yes, we're going to post the CMEs on the website, and we're going to have sort of like a web blast and ask people like that, more or less,
very good.
online.
Thank you very much.
Happy to have you for to use the slides. Thanks, Nick. We'll talk to you soon.
You bet. Bye bye.
Thanks, everyone.
Thank you all. Thank you, Dr. Laham. Thank you.
Thank you.